morning, good afternoon. I'm Wayne Detmer. I am a family physician. I work at Lawndale Christian Health Center. You guys can just sit, yeah. And I have been at Lawndale for 26 years. My wife is a pediatrician. We've raised 4 great kids there, and welcome to our panel. So this is a talk. It's not exactly set up the way we were wanting, and we've added a special guest today. We had 4, now we have 5. But the goal today is to have a discussion, to think about sort of, does theology matter? Or if it matters, why does it matter? And that type of a thing. And so we're not going to end up with a well-formed theology of disability, for example. That's not the goal. But the goal is to start to talk about theology and why does it matter for the work of those who would endeavor to be a part of living out the gospel through healthcare among the poor, right? So I'm going to pause there, and I'm going to ask the panelists to introduce themselves, say where you're from, whatever you want, family, what you do, whatever. Starting with Dr. O.
Thanks. I'm Louisa Olushoga. I am a psychiatrist at Lawndale Christian Health Center in Chicago. Been in Chicago for several years, but originally from the East Coast. Married, and I have 3 daughters, 13, 10, and 3.
Good afternoon. I had to think about what time it was. Good morning, or good afternoon. I said that, and I always want to say good morning. Jordan DeVeaux is my name, and I am finishing at Duke Divinity School right now. I graduate this May, and I'm very excited about that. Thank you so much. And I am the spiritual care intern at Lawndale Christian Health Center, and I care deeply about geriatrics. Yeah.
Hi everyone, my name is Russo. I am a senior at Baylor University in Waco, Texas. I'm originally from Connecticut, and next year I'll be attending medical school at Baylor College of Medicine.
You guys can make noise.
And Izzy's a medical humanities major, which is important for this discussion. Okay. I'm Chad Thompson. I'm a family medicine physician. I am clinical professor, assistant professor at Baylor, teaching medical humanities courses, and also faculty with Waco Family Medicine, so teach family medicine residents as well. And I have a wife and 2 kids, and that's all.
Hi, I'm Lauren Barron. I'm really glad to be with you. I'm a family doctor as well. I trained at Waco Family Medicine, and right now I'm privileged to head up the medical humanities program at Baylor University. I always say that Baylor's my mother and Waco Family Medicine is my father. And if you want to know what medical humanities is, here's my pitch. It's the best of a liberal arts education with a medical focus. It's a bridge between the art and science of medicine, and we're trying to turn pre-med and pre-health students into humans before their medical training turns them into gods, robots, jerks, or some combination of the above.
So you can see we have a pretty cool panel today. I want you all to know that when they asked me to do a workshop, I sort of leaned on my spiritual gifting, the gift of prophecy, the gift of teaching. My spiritual gifting is the gift of delegation. And so I thought, you know what, this organization brings so many amazing people together that what I want to take this time to do is to get not just me in front of people, and trust me, I love myself enough and wouldn't mind being in front of y'all for an hour, but I wanted to get these 5 people for several reasons, because they represent the breadth in some ways of what CCHF is, right? This isn't just senior clinicians on this panel. You look at the diversity, we have an undergraduate, just an amazing group of people, and part of the reason we wanted to have that diversity is because part of the idea of why we would talk about theology at a CCHF conference came from both my own experience personally, but also my experience working with gap year interns largely, and seeing the hunger for wanting to understand how our Christian faith ought to inform the practice of medicine, not just to be in default mode. Let me start with a provocative paragraph from a book written by a historian who was at Wheaton at the time and then went on to finish out his career at Notre Dame. I think he's at Regent now. But Mark Knoll wrote a book in 1995 called The Scandal of the Evangelical Mind. Now, I know that word is like a 4-letter word now, like whatever that meant back then doesn't probably mean the same thing. But let's let's read what he said, and I hope to set this up as to why we're even talking about this. In this book, The Scandal of the Evangelical Mind, the first paragraph reads like this. The scandal of the evangelical mind is that there is not much of an evangelical mind. An extraordinary range of virtues is found among the sprawling throngs of evangelical Protestants in North America, including great sacrifice in spreading the message of salvation of Jesus Christ, open-hearted generosity to the needy, that's us, right? Heroic personal exertion on behalf of troubled individuals, and the unheralded sustenance of countless church and parachurch organizations. Notwithstanding all their other virtues, however, American evangelicals are not exemplary in their thinking, and they have not been for several generations. Right, and so now I'm not going to talk about what you think about that. I think that's spot on, at least for me. If the only person he was writing about was me, that describes my upbringing. Because I grew up in the church where the answer, if you're struggling with something, well, the answer's in the Bible. Well, sorta. What's it say about in vitro fertilization? That's why Alan Verhey, the theologian from Hope, had to write a book called Reading the Bible in the Strange World of Medicine. It's not as straightforward as it seems, at least to me. So when I read this, I thought, he's talking about me. And for those of us who grew up in the Christian tradition, I think we get sort of used to it. We talk about being in a bubble in college. It's sort of like the college bubble. Well, there's a Christian bubble too. And so sometimes I would look at other religions and say, they believe what? Like what? But if you didn't grow up in the Christian bubble and you listen to our story, it's as nutty as any other story. God becomes a man, what? And born in a what? It doesn't make any sense unless it's true. If it's true, I've got some amazing interns, and every year they try and outdo each other for my birthday. It's December 18th, in case anybody's wondering. And this year, what they got me was a hat, a baseball hat. And on the side, there's a chicken, because I got backyard chickens, because somebody told me they were therapeutic. And on the front, they took a quote from apparently something I say when I give these tours. And what it says is, if the story's true, it changes everything. And I say that mostly to the Christian groups that I take through on tours of Lawndale. I don't have to say that to the non-Christian groups because they know that. But to the Christians, I say, if the story's true, if God really did become a person in the form of Jesus and live among us, it changes everything. Not just how we think about the latest hot topic bioethical issue of the day or our political posture. It changes how we think about things like, what is medicine for? What is my relationship to the patient? How do we design buildings that reflect the dignity that we say we believe that all people have? So for me, that's where part of this is coming from. Now, some of you all know John Patrick. He's a famous British speaker guy and often has lots of students come to his talks. And he talked about some biblical interpretation. And so we all know the verse in where what's the greatest command? Somebody tell me. Just shout it out. Yeah. Well, I don't know what you guys said, but it's. So he said, and this is Matthew 22. I'm going to read it. You shall love the Lord your God with all your heart, with all your soul, and with all your mind. Jesus was quoting something that was from Deuteronomy. In Deuteronomy 6:4, it says this: Hear, O Israel. That's the Shema, right? Hear, O Israel, the Lord your God, the Lord is one. You shall love the Lord your God with all your heart and with all your soul and with all your strength. That's not what Jesus said. What was the difference there? What was the word he put in? Mind, right? Now, John Patrick, this British guy, he said that the reason Jesus put that in there is because he knew 2,000 years later, American Christians were going to need to be reminded that they need to love God with their mind as well as their heart. So that's where we are today. We're here because I think that many of us who do this work, we came into faith in Christ, and then we decide, and we understand that our job is to care for the poor, to care for the things that are on Jesus' heart. But medicine, the business of medicine and the practice of medicine, in my opinion, is not heading in a particularly Christocentric direction. And so I think that it's important for us at times to combine both our service and our heart with our mind and engaging our mind. And so this group is going to help us think about these things. So we just picked a few topics to start off with, but I'm also going to invite you all to share stories. If you have stories or thoughts, to invite them in too. So the first thing we're going to open up with is on this idea of theology of disability. Now, for some of you, you never even thought about stuff like this. For some of you could be up here teaching this. But we're going to just open this up and see what happens when we give our panel space to talk about some of these issues. So the first one I'd like to pose to our panel is, why or does the church need a theology of disability? And what practical difference does that make to you in your current wherever you are, whether a student or whether a practitioner or whether an instructor? And I'm going to ask Dr. Chad Thomas to start out.
Okay, so in order to make this somewhat interactive, I'll actually throw that out. Would anyone offer, like, what does that mean to you, theology of disability? Can someone, how many of you have, like, thought about this, a theology of disability? I've heard that phrase. It's like something you think about. Okay, someone who's raising your hand, like, what does that mean? I saw some hands.
Put your hand down.
Put your hands back up. Okay, so a way of thinking about the reality of human limitations, what you said, and disability in light of the revelation of Scripture. So it's kind of thinking through, how do we talk to God or God talk to us about disability? So there's the mantra, there's two kinds of people. There's people who are disabled and those who will be. So the reality is, speaking about human limitations, all of us at one point will be disabled, at least in the ways that we kind of think about it, because we inhabit bodies in the way that God created them, which are finite and limited and can be wounded. And so this matters, I think, when we, in medicine, and what we think medicine is for, and how we relate to our patients and goals of care and treatment. So, one of the things that I teach a course on the U.S. healthcare system and talk about the whole industry of long-term care, and one of the central thrusts of long-term care, the goal is to maximize functional independence as long as possible, essentially. So how long can we maximize someone's functional independence from others? But we need to have a theology of disability that helps us understand how we relate to each other in our bodies, that is limited, that requires an interdependence. So there's messaging that we get from how our healthcare system is designed that tells us one thing about our bodies and what they're for and how we should maximize our productivity and efficiency. And in medicine, one of the things we do is we try and maximize our patients' functional independence. And that's not always wrong, but if we don't situate it in a theology of what it means to be disabled and how a patient might understand their disability in the society that we live in, we can cause harm or kind of push in a direction that may not be thinking theologically about what we're doing in medicine. So that would be my first thought. But if anyone else wants to jump in, or if you've had an experience with a patient where you think about this example. You got one.
Yeah, I'm coming from the perspective of the church, so I do think it's important that we have a theology of disability, particularly because the church was at the forefront of people advocating to have exemptions from the Americans with Disabilities Act, and that history is deeply troubling to me. The church had made the statement that, we may not be able to afford ramps, and we need to make these exemptions for us. And if anyone should be able to say that they're more valuable than $1, it should be us. So that's my first point of concern, but also whether or not someone can get baptized. That's a real issue for families. Can someone be immersed? Does someone have what the intellectual capabilities to agree and profess? So what does that mean? So from the perspective of the church, it's deeply concerning if we don't know what we think God thinks about people with disabilities. So that's the perspective I'm coming with. Yeah.
Well, further thinking about churches, I don't have any clinical experience because I'm an undergraduate student, but what I do have is the experience of growing up, going to church, and seeing how physical spaces are formed and kind of how that shapes our imagination and the way we think. And so the way that crying rooms are developed in churches, and that's something where young children who are making a lot of noise were put, but also in my church, it was older children and adults with profound intellectual disabilities and also the elderly. And so just an interesting case of the way we have visibility of people who may interrupt our worship or make that experience unpleasant for us really should bring to light how we think about community, how we think about what a church is for, and how we relate with one another, and how that's fundamentally how we were created, and yet we create physical barriers to kind of separate that in the place where those barriers should not exist the most.
The things that come to mind when this question is posed is, I love what you said, those who are disabled and those who are going to be. It was a story from my medical school days, and there was a gerontology lecture, which, by the way, I didn't train in this century or in this millennium. It was in the 90s. And anyway, it was a gerontology lecture, and that's when gerontology was like new, which seems kind of ironic. So there was a lecture about gerontology, and I can remember it was a sparsely attended lecture. By the way, students, that's when they required us to go to lectures in medical school. And I remember the gentleman getting up, the gerontologist getting up and talking about what he did, and then he said, before he proceeded to his lecture about geriatrics, he said, before I give you my lecture, I want to make sure you know that we have someone in our home who is full care, 24-hour care. We have to feed her, we have to bathe her, we have to take care of all of her activities of daily living and make sure she doesn't harm herself. And she is the light and the joy and the center of our home, and that's my 18-month-old daughter. And I knew when I heard that story, it changed everything for me. Because his point was, these are the same things that our elders need. I know the question is disability, but I'm thinking in terms of, the other end of life. These are the same exact ways of caretaking that we do for our children, and yet we approach it completely differently, and that's always been a story that's really, really shaped me. The second thing I want to commend to you in this area, if you want to dig in, is the work of Kay Toombs, who's an emeritus philosopher of an emeritus professor of philosophy from Baylor University, and she's done a lot of work in phenomenology, and I feel really proud that I can even say the word phenomenology. And then if you're really advanced, you can say phenomenological, but that's advanced work. But one of the things that she talks about, and she has MS, and her work is incredibly accessible as a philosopher and also someone who is in a wheelchair for 30 plus years. And she always makes a distinction between healing and curing. And she talks about the fact that you can be cured but not healed, and you can be healed but not cured. And she would tell you, if she were here today, that I just had tea with her on Monday, that she has an experience of healing, even though she hasn't been cured of her MS. And so I think that's an important distinction to make. She uses the example of a woman, say, who's had to have a mastectomy from breast cancer, who's technically, cured from her cancer, but is still, having problems with, that new orientation to her own body. So healing versus curing, and then the story from that gerontologist is what I want to contribute.
Thank you. Let me say that you may have noticed that one of our panelists who was originally listed isn't here. Far Curlin, who's a brilliant physician-theologian, started the program in religion and medicine with Dan Slomacy, University of Chicago, had a family emergency, and so he wasn't able to be here. But it was largely through interacting with Far, when even as a resident he was at Lawndale, and he's this brilliant thinker, that I came to understand something that just blew my mind. And that was that there was an entire body and an entire culture of people, Christian people and non-Christian people, even thinking about issues of theology and medicine that I had no idea these people even existed. People, I'm obsessed, and I'm right out there. I'm going to let you know I got some things I'm obsessed with. I'm obsessed with Duke Divinity School, which is why we have some representation up here. I am now obsessed with the medical humanities program at Baylor, which I think must be the best preparation for anybody going into any form of medicine of any undergraduate school in the United States. I'm going to put that out there, and then you guys can challenge me, and maybe next year I'll have a different tune. But that's why they're up here, because I want you to know that there are institutions and there are places where people are thinking about these things. I was tempted. I didn't get up in time before I came down here to do this, but I thought, I wonder if just even on theology of disability, we saw how many people have even thought about that. It wasn't the majority of folks, right? I was just going to grab the stuff off of my bookshelves, and I'm a novice. I'm a baby. But I bet I have 25 books written on the theology of disability. 25. Who even knew that there was one, right? Tiffany Borio's back there. She can tell you. Like, we even, Daniel Song was one of my gap year interns. Is he here? Daniel here? Daniel is back there, and he came and he drank the Kool-Aid, and he was this brilliant guy from Princeton and all this stuff. And he I think, felt sort of this need to have a foot both firmly in the world of service and caring for the vulnerable and the marginalized, but also deeply rooted in right thinking, theology, and recognize that there was a gap there. So when 2015, when he went off to Yale Medical School, we made a website called the Good Physician Project. And all it was supposed to be, it's called a curated library for faith in the practice of medicine, because we knew that there were a lot of people like us out there who were wanting to serve Christ through medicine, but that had no idea that there was this whole body of work being done now and in the last 2,000 years, thank you, Catholic Church, that would help guide us. They have an encyclical, guys, called the Theology of the Body. It's huge. It's so big they had to write a mini theology of the body so you can understand the main theology of the body. But the Catholic Church has been doing work on this type of thing for 2,000 years. And as a Baptist who grew up just down the river, I had no idea until I was 35 years old and came to Lawndale. So I really appreciate what you all have shared in this. I'm going to ask, are there any thoughts or questions now and reflections from what was said up here? Any audience want to share anything? Dennis? Right, so I wish we had, because they're recording this, and I wish we could, I need to repeat it. Can somebody repeat the question? Did you guys have it? Because it's too long. I lost you after the comma. But
you said you're trying to reconcile this idea of maximizing functional independence, which is often an aim that we see in medical treatment, versus the idea in Scripture of it's not good for man to be alone. You're talking about Genesis, I'm assuming. And then, can you repeat the last part? Yeah, the Christian emphasis or scriptural emphasis. You said cultural emphasis on healing.
Getting better, healing the disability.
Healing.
When the disabled don't consider themselves at a loss.
Yeah, so John Swinton is someone who's written quite a bit on theology of disability, particularly with dementia and profound intellectual disability and other mental health struggles. And he worked as a mental health nurse for many years, so he's kind of writing with a very practical theology as a practitioner. And he tells a story of a woman who's deaf and was asked about her what she thought heaven would be like. I think may not be getting the whole story correct, but there's a conversation around heaven, or she even maybe had a dream about heaven, and she was retelling this story of how she was in heaven, and she said, and Jesus signing was amazing. So think about that for a second. Like, her understanding what heaven is like is a place where Jesus and maybe the community, their signing is so amazing. It's so much better than it is here. Not, I could hear him speak for the first time. Because that's her embodied experience was how she connected with God here. Why would that be taken away later? So how we think about healing and how we think about the new heavens and the new earth and resurrection, we need to learn from those who have navigated the world with disabilities and how they relate to God. We have a lot our theology needs to be informed by that too.
This is stuck. Sorry, Jordan. I would say that as a psychiatrist, this is the sort of the space that I occupy often. It's not uncommon to sit in front of a person who either doesn't have insight into their need for something that maybe they actually might need, or, I mean, even the reality of there's a voice that actually feels like is a comfort to me, and taking this medication might actually get rid of that. And I would say, I know we're sort of coming around to this, but I'm no theologian or biblical scholar. I think what I come and bring to the table are just my experiences both in life and professionally. And, you know, the longer that I sit with people, you know, the longer that I live, you start to realize that there are not many degrees of separation between you and the person that you're sitting in front of, regardless of what is happening. And what does it mean to actually meet people in that space in a way that you know, rectifies and unifies their ability to kind of be in fellowship with other people? I think coming out of psychiatry training, there's a lot of work, and I mean, I think for most of us, doctors and physicians as healers and fixers and completing things, you know, but psychiatry is such a humbling place because oftentimes things sort of get left a bit undone. And you start to kind of reorganize yourself as to what is the goal, you know? Is the goal to make it to where this is never a thing? And unlike many other medical specialties, you know, some people are fortunate enough to go through life and never have to be admitted to a hospital, you know? Everyone doesn't always have to deal with cancer or have some sort of thing that they're seeing specialists for. Everyone suffers, right? Everyone deals with the pain. Everyone has some reality or some point where there's such a real struggle, which allows me to be an image bearer of God sitting in front of another image bearer of God saying, where is my role here when I can't just take away suffering? I can't really just undo the depression. I often can't undo the anxiety, and sometimes I also can't undo the psychosis, right? So where is that work? And I think where you're talking about is I often meet my patients in a place of sort of redefining what functionality is, because functionality isn't really measured by what I understand as to how things are supposed to be done throughout the day, but rather what does it mean to sort of have a healthy living, to be able to be in fellowship and in engagement with people around you, to allow yourself to be in a place where people can pour into you, because I do feel like that is what God has for us, right? It is what God has for us, to be in community and to care for each other and to love each other. You might be able to do that with voices, actually, right? If we just take some time to think through that. And oftentimes it's possible to leave those rooms or spaces when a depression persists, despite, you know, max doses of Zoloft. And so kind of rethinking, and for me as a psychiatrist, you know, my faith really informs where my goal is, which sometimes doesn't completely align with where I've learned in the textbook that my goal should be.
Yeah, I want to echo all of the things, but the first thing I'm thinking about is the first part of your question around us not meant to be alone. As we're pushing towards functionality and independence, and I found it so profound that you said independence from others when you were speaking before, and that really stuck with me. But when I was in high school, I was a part of an organization that partnered our high school with another high school that was specifically for those with developmental and intellectual disabilities, and we would have events together and that kind of thing. But the pitch they would make to us was that on average, at that time, this was around 2014, 2015, on average, a person with a developmental or intellectual disability had 3 friends, and one of them was a caregiver. So as we're pushing towards functionality and independence, organizations are forming to then undo that and surround people with people. So that is something that I find troubling. But I also would say, is the person disabled, or is our world fallen and unaccommodating? And that makes me think about Jesus signing. It makes me think about the fact that our eschatology can have space for for more than we can imagine, more than we say that we can afford, more than we think we can legislate. I think that the agency of the harm or the ill that needs to be fixed sometimes is placed so much on the person, and not enough on the institutions that we occupy, that it's troubling to me as well. But that's something that I've given some reflection to.
On May 6, 2000, in the year 2000, we had at Northwestern Hospital, my second son was born, Simon, who's big. And my wife, the pediatrician, and I were just rejoicing. And I went back to Lawndale. I had the privilege of being able to live, if you all know Art Jones and Linda, we got to live with them for a few years. And so I remember being back there. And the next day, and Gina called me, my wife, who's this brilliant, amazing person and a great mom. She said, I'm a little bit concerned. I said, what? She said, his hand movement. Is there something going on? And I said, well, what did you do? And she said, I called the resident, and they came down, and they looked at it, and they said, he's fine. And I said, and you know, my wife, don't mess with our kids, right? And so she's like, get the attending down here. And so the attending was on the way. She called me back later and said, they're not sure. I said, well, what do you think it is? She said, well, it might be seizures. And so they did an EEG, and for the next several years, Simon had seizures. It turns out he had a neonatal stroke, and he has cerebral palsy. Nothing like having a child with a disability to put theology of disability at the top of your list of things you care about. The discussion this morning in the Detmer house over the phone was, are people going to be restored in heaven? She said, my wife said, there's a theologian at Calvin College. Any Calvin people in here? Yeah, there we go, Jonathan. And who doesn't think people are going to be restored, normal, in heaven? So then we debate about that in my family for hours. But I think that for some of us for whom that might seem preposterous, the way learning about people who think about the theology of disabilities help me is they talk about the cult of the normal or normalcy. That we sort of assume, right, that there is this thing that's normal. Where do we get that from? I don't know, our glossy magazines maybe, right? Like there's a perfect size for a woman. There's a perfect look for a guy. Perfect weight. But if you look 2,000 years ago, what was considered perfect in the Greco-Roman world wasn't the same. Bodies were bigger. That was considered beautiful. Skin color, the whole thing, right? And so what this hanging around people like this and reading has helped me to realize is that no, we can't just start with our cultural assumptions. We have to challenge our cultural assumptions about what it means to be normal. Because where's the line? Right? It's easy to say if somebody had a leg and then they stepped on a mine and got it blown off, that normal for that person might be to have their leg back again. But what about a man who's 5'6"? In heaven, is there like an average, is he going to get up there a little bit? Or what about a woman who's 6'5"? Maybe she doesn't want to be 6'5", right? And you can see how this starts to challenge some of our assumptions. And so I want to take it from now the theoretical and challenge either our panel or you all to say, but what difference does it make for me in CCHF? What difference does all this talk make tomorrow when I go back to seeing patients or when I go back to ministering to families who just found out that their baby has some kind of a chromosomal deletion? So, panel, do you have any thoughts or any practical examples or stories of why this might be important to think about?
As you were, go ahead, please. As you were speaking, I just thought about the resurrection and that Jesus' wounds were maintained. And I think about that often, like why might he have kept scars for us to see? Was there some healing work going on in just seeing them? Did he know Thomas would need to see evidence? Was there something that he understood was now a part of who he was that he could not discard after this experience? So it makes me think about the question of what heaven might be like And it makes me think that if Jesus could find value in his wounds and alterations, that we may be able to find some in ours and our patients also, in this life or the next life.
The thing I spend a lot of time thinking about when you're talking about what practical difference does it make? For me, I think it's a matter of orientation and posture toward the patient. So I haven't heard any fancy theologians who've written lots of books talking about this, but ain't no doctor in the Bible ever healed nobody. I mean, somebody help me, because I can't find any place where a doctor healed anybody. And then you're going to say, well, Luke was a doctor. Well, yeah, he was a scribe. Like, he was a scribe when there were, like, scribes, not like scribes. But, you know, Luke was a doctor, but he was a scribe. And so for me, I want to say something that might be a little controversial in this group, is I'm hesitant to assume the role of healer. I know a lot of Christian doctors, that word doesn't feel comfortable for me. It feels like I get to be a guide, you know, what a guide does, like through a foreign country, foreign language, you know, go here, don't go here, holiday, all of the culture, history. But I think what I want to say for me is studying the Bible and the healing ministry of Christ and the disciples. For me, it helps as a matter of humility, in terms of the posture that I have with patients. And the other way I think it makes a difference is that the question you had, Dr. O, like, what is the work? You know, what's trying to happen here? What does love require in this room at this time? What's trying to happen here? So those are some of the practical ways I feel like it matters to me in terms of changing the posture of the way I was educated as a physician.
So I've been at Lawndale since 2020. I came on October of pandemic, and so there was that. But I've landed in 2 spaces at Lawndale that were just not part of my calling for myself, actually. I knew I came to be a psychiatrist. You know, I was really passionate about women's health. But today, there are a couple of ways that I work at Lawndale. One is with our unhoused population throughout Chicago, and the other is with our geriatric population. Now, ask me 5 years ago, and I'd say no thank you, and definitely no thank you, right? Like, these are not populations that I signed up for or felt like, you know, this is what I came into medicine to do. And I think a conversation like this has really informed the way that I sit in front of these patients and I work with these patients, and part of why I've almost developed such a love for working with these populations. And most recently, actually, the morning before we left, Wednesday morning, I had a clinic over at our senior day center. Again, this is a new thing. I'm in this our PACE program, and I don't do old people well. I don't do kids well, and so maybe there's a little, you know, there's like it's just hard for me. But there's this need that, you know, we've got this beautiful center and we've got this program really caring for our seniors and just the psychiatric needs that come up, you know, neurocognitive things, you name it. So I was like, okay, let's get a shift going. I will figure it out as we go. A few weeks ago, I met a very sweet woman with dementia that also has these, you know, what seem like functional neurologic jerking things that don't really have an organic place. I met with her and I sat with her and her caregiver for about an hour and a half. So sweet, just such faith in the Lord. Memory is, of course, you know, not great. And she was really just concerned about the burning. She has a lot of neuropathic pain in her hands and her feet. And so we just spent time talking and, you know, laughing and whatever. And I was like, well, here's the thing, you know, there's this medication that you've got that's supposed to help with this neuropathic pain, but you're not really taking it because you're not remembering to take it every night. You know, so we sort of sat together to try to figure out, okay, how can we get you to get this medication? A caregiver on board, PACE team on board. So fast forward to Wednesday, I get to clinic, and Lisa Werner, actually, who runs that PACE program, is like, oh, I've just got to tell you, when you sat down with this woman, she came and told her that was like, it was so great that you guys had this conversation. And she felt like her pain was all better. The last couple of appointments, she felt her pain was gone. And I'm thinking, well, praise God, because in psychiatry, you take the wins where you get them, because they don't come, they often don't come very directly. And I was just so excited. And so I was going to be seeing her again Wednesday morning. And she walks in, and I greet her, and she says, "Who are you again?" And I'm thinking, I missed that window, right? But surely her pain is gone, so we're going to ride that out. And the first thing that she said when she sat down is, "I've got this terrible burning in my hands and feet," right? And I'm thinking, so the human and the flesh in me is just like, come on. We had this win. It's documented here. You certainly said this. I feel like the pain was gone, and I really want to occupy that space with you so I can celebrate that and we can pick up where we left off. The Christ in me, though, starts right all over again with her, right from the beginning. "Hi, I'm Dr. Olushoga. Tell me about the pain in your hands. Let's talk about the medication." It was like I was, reliving a day over again, right? But my desire to dignify this woman in front of me, it's not her fault that she can't remember anything that happened 3 weeks ago or even last week, or I think actually it was 2 days ago that she told them that her pain was gone, right? None of that is there. But the Jesus in me is looking at the Jesus in her and saying, you still deserve my full attention, my full education about this medication, our talking through it, you're asking me the same questions, me looking at your caregiver like, "Hey, that medication at nighttime, we should," so you can get up and do it again, right? Now, the human in me, that's exhausting. That's like, we're gonna get back in 3 weeks, I'm gonna be like, "Hey, I'm Dr. Olushoga, this is the pain in your hands and feet." But I think that's how our faith informs what we do and why it actually makes a difference. Because someone else would say, or medicine would say, "I wrote it down, it said it this way, the medication is there, it's documented, check, check, check. I've done all the things that medicine tells me to do." My Jesus, though, has me sit right back down and start that conversation all over again. So it makes a difference because for me, it's a thing that drives my treating the human in you, not the project in you or the psychiatric need in you. It's my meeting you in the place where you, the human, are, and I bring my humanness to that to dignify you.
Can I just continue on with that? So as you're sharing, it just made me think about how often in medicine we so desperately want results and measurable outcomes. We want something documented in the chart that shows that what we did mattered and made a difference. But what I'm hearing and how you approach that is that there's something that we offer in medicine or in health-related fields that's sacramental. The healing there was the way that it was this embodied connection, this rhythm of how you relate to each other, that there's, and specifically with patients with dementia, the memory may not be there, but what people remember is what's in their bodies. So this sacramental going through that was what was most likely healing, was not that you actually got to take the medicine. It was this ritual, a rhythm of being together, holding the hands that are in pain, this sacramental. So if we can remember that in the way that we approach our work in healthcare and not being the pain, well, I thought we fixed that, that we can participate with others in this rhythm of that's sacred and sacramental in some ways.
I was just going to say a really funny moment, just to then, because I think sometimes we have these conversations and it seems like the people either up here in front of you who are talking have so much more power or ability or whatever, right? There was a moment there where she started to describe the pain to me, and I said, "Does it feel like burning?" Or I think I said something like, "Is it like sticks in your hands?" And she said, "How did you know that?" And for a slight moment, I thought about writing this because I'm a doctor and I know these things, right? But then I was like, because you told me, actually, 3 weeks ago. And then she said, oh, okay, right? So there is still a temptation because and that's a temptation that I think it's just there, right? There's a temptation to want to take it. I want the glory, I want to know, I want to heal, I want the feedback. There's a temptation, and I think our theology also informs and helps our ability to work to resist, not perfectly all the time, but to resist that temptation.
I think about my friend who I do caregiving for. So I first started as a caregiver for a man with ALS disease in Durham when I arrived at seminary, and I love their family. And it was my first time experiencing ALS that's up close, or witnessing ALS up close. And one thing I noticed about him, his name is Napoleon, and he is unable to eat. So he eats through a feeding tube. And I noticed every time he would order food for the caregivers for dinner, he would get so excited to recommend food places to us. And I noticed over time, I'm like, you really like sharing your food interests with other people. Like, you like seeing them enjoy it. It's almost as if he's having it himself. And he's like, yeah, I really do. And I think that makes me think about how we define quality of life, and just how we might impose what we think is a good day onto someone else, and how that changed so much for me in terms of what I thought was a quality day. Him being able to share food recommendations with other people and watch them enjoy them rather than experiencing it himself. So I think in a practical sense, thinking about what we're aspiring to, I think is really important in terms of just what life we want for our patients, or what they want for themselves, more importantly.
So I can see we are now 45 minutes into this, and we are not even close to talking about question number 2. So we might just stay here for a moment. But for those of you who are wanting resources, somebody up here mentioned John Swinton. If you don't know any other name, write down the name John Swinton and go listen to him, because he helped me in several ways. And here's one way. He said at some point, and others have said things like this, Martin Marty, Martin Marty, who just passed, this amazing Lutheran theologian, wrote a book called The Gift of the Child. But they both said the same thing. They said, we have to be careful even in the language we use around disability and illness. He said, because in the way we speak in the United States, we talk about, we often use the illness to describe the person. So we say the schizophrenic, all right, or the autistic kid, the diabetic. And he said, and especially in mental health, especially in the world of disability, if we're not careful, the adjective becomes the defining factor. It becomes the person. And in what Martin Marty said and John Swinton both said is we have to maintain the dignity of the person created in the image of God. So we say the child who suffers from autism, the woman living with schizophrenia. Right? That's why, because sometimes, there's this touchy-feely stuff and people experiencing homelessness, and in my family we're like, Dad, I'm a person experiencing Christianity right now. Stuff like that. You can go too far probably with that. But I think it's important. The words we use are important. So even if you think on the practical side, not just in what happens, with the patient before me, but how we think about and how the language we use to refer to people with disabilities is very, very important. So John Swinton is one. A couple other quick things. 400 BC, the game changer for medicine was what? I know you all know what happened. Big changer in medicine in 400 BC. I knew it. I said Morgan Wills is going to say it. That's what I'm talking about. You never let me down, baby. The Hippocratic Oath is the foundation. Now most medical schools don't say it anymore because it talks about not ripping people off and killing people, and so now we whitewashed it. There are a couple medical schools that still say it, but back in the day, when Dr. Barron and I were in school, we had to say the Hippocratic Oath. You know what was spectacular and one of the most transformative things about the Hippocratic Oath, why it changed the practice of medicine for the next 2,000 years, is because primarily there was a commitment not to kill. The physician made a commitment not to kill. Now you say, well, what are you talking about, Detmer? How many people in England right now are born with Down syndrome. You know how many? Not many. You know why? I think that, and I'm not judging anybody. I'm not judging anybody here, but I'm saying this is where the rubber meets the road. As people of faith, as Jesus followers, what do we think of a person with Down syndrome? What do we think of a person who has intersex chromosomes? What do we think of a person who has profound intellectual disabilities? I mean, again, we live in this world. We are dumb. J.I. Packer said that Christianity in America is 3,000 miles wide and a half-inch deep. Do you all know that in the 20s, the U.S. Supreme Court legalized the sterilization of people because of their intellectual status? They said if people were below a certain IQ, you could forcibly sterilize them. We talk about Nazism and and Hitler and the Jews and stuff. You know where a lot of that started, though? It started in the professional medical establishment, with sort of this idea of relieving suffering, right? We hear these people are going to be born with these profound disabilities, so let's take that away. And one thing leads to another. We are heading back there. People say to me, if there's one book to read before I go to medical school, what is it? You know what my recommendation is? Brave New World. Because we are practically there. So I'm going to pause for a minute, ask for any questions. I know that, how long do we actually have? You gave me the 5 minutes, but we're going to run it right up to the limit. 4:45. I want to pivot hard on, you have a question?
I have a comment. So I'm actually PM&R, physical medicine and rehab. How do we help people still maximize the quality of their lives?
Thank you very much. He talked about how PM&R is really built on many of the foundations that we're talking about today. And so I think that we're going to just, I don't know if we should pivot. Anybody up here have anything to share about theology of disability? I want to just touch briefly because it is. I put it number 2. I was going to put it number 1, but then it was very controversial, so we said we're going to put it number 2. And this question of mental health and a theology of medicine, like, because that's a tough one, right? Like, so many of us probably grew up in churches that said, if you're depressed, you need to lean on Jesus, right? Have the faith of a mustard seed, all that stuff, right? And so there's so much bad theology out there that I want to at least give, maybe, are you the only, does anybody aware of any other psychiatrist at this conference today? That's what I'm talking about. We're going to take advantage of the fact that Dr. O's here, and she's going to, I wanted her to just share briefly and to help us think about how her theology informs mental illness, because that's a tough one, right? If I can take a medication and not hear voices, if I can take a medication and not be depressed or not be anxious, which one is the real me? Right? There's all kinds of questions we have. Or what? So anyway, I'm going to just give Dr. O a minute here to talk about theology and mental illness, and then if we have time, we'll go down a little bit down the panel.
Got 30 seconds to wrap it all up for you. And I will say before, I'm only going to say a few words. I think it's these things are conversations, and so I'm open to have conversation with anyone after this or anytime during this conference. But I would start from a place, I came to Christ in college, in undergrad. I came from a Catholic background, but really just met Christ in college. And as I was going to medical school, my theology in psychiatry is the same thing that informed my theology in medicine, which is that, to me, it goes without saying that any sort of infliction or ailment, be it something that is physically felt, emotionally, mentally felt, spiritually felt, does have a door that there's a spiritual realm at play. And I would say that very strongly for diabetes, for pneumonia, for asthma, schizophrenia, depression, anxiety. That in this fallen world, we know that there is a whole realm of just spiritual work against us and God's purpose for us. And I think when I start there, instead of, sort of otherizing psychiatry and mental illness, starting from that starting point, it's a bit easier to have some of the other conversations because it's not really that different. Now, where it's different is culturally, right? Like, if something wrong with my organ, I feel okay, and I can go get that looked out. But if if I'm just not feeling good, I should be able to deal with it. So, it's been said in a number of different ways to me. I've read it in a lot of different ways that the reality is that when we're looking and thinking through the use of something like psychiatric medications, we're using it as a vessel in the same way that we use anything else that we're doing as a vessel. Recognizing that psychiatric medication actually isn't going to be the thing to fix it all, right? But the thing maybe to bring your head above water so that way you can function and live purposefully in the life that God has for you. Now, the conversation of when is it the threshold at which I'm supposed to do that? Or what does it mean to not have faith? Now, as a Christian psychiatrist, I feel like God called me into psychiatry. And I don't feel like God called me into psychiatry to be in psychiatry and say, I don't use medications because God called me here. I think God actually gave me a gift to be a psychiatrist to toe this line and say, you know what, in the same way that he's given, the ID doc the skill set or the PM&R doc the skill set, there's a certain set of tools that I have to help, recognizing that ultimately it's God at the helm, right? The same way it is when you walk into your oncologist's office and you're hoping this thing works out well, or you've got the patient with uncontrollable diabetes. It's not me. These are the vessels and the tools that I have at my disposal to use. And I would always say that psychiatry is it feels to me one of the most humbling places in medicine because we really don't understand how the brain works, actually, right? Like there's a lot that we just don't get. And God has graced us with sort of a snippet of something to come up with some psychopharmacology that sometimes can be helpful and sometimes isn't. But I think if we start from this place that whenever we think about infliction and thinking of being image bearers in this fallen world, there for sure it is not without the spiritual realm that is God. But that goes without saying for every single thing. Psychiatry is not othered in it. So then what do we do when we come to our humanness and the limitations of what our knowledge is, and to include those tools that we have, how do we use that for God's glory? And that being the question for everyone in here, right, who's practicing in healthcare, how are we using our skills and our tools and all the imperfections that we have for God's glory? And if that's the direction that we're going in, then it's really hard for me to say, like, well, this tool doesn't count. But this is also where I've landed after, wrestling, and so I will leave it at that and say I'm happy to always have conversations. But that I think is where my springboard is to understanding.
Thank you. I know we could go on, but I probably have to end it. But I'm going to say that our panelists will be willing to stay up here and chat if there are folks that want to chat. I've already given my shout out to Baylor and to Duke. It goes without saying Lawndale, right, is a pretty special place, and it's all the grace of God. Anything, right, that we've done, we've been able to do that's good, whether at any of these places, is all by the grace of God. The last resource I want to introduce you to is a book I picked up in the last month. It's called On Getting Out of Bed, The Burden and Gift of Living. Every 5 or 6 years, I read a book that it makes a big difference in my life. This is the one. The last one was Life of the Beloved in 2018. So if that puts this in perspective, this is an English professor from Oklahoma Baptist University who struggles himself with some mental suffering. And it's the most reasonable, theologically informed understanding of mental suffering from Christians that I've ever seen. And because I'm especially concerned, as you all are, about the increase of anxiety, depression, and suicidality among young people in the United States, I think this book is prophetic. So if you want a bit of an encouragement, if you don't like it, it's fine, but it's helped a lot. The people that I know who have read it have said it's been really, really helpful. So On Getting Out of Bed, The Burden and Gift of Living. Thank you all for your patience today and for your questions, and may God be glorified.